You can imagine when you are in a community. My first internship, is it internship we call it now, or externship, the one where you go and work at a community pharmacist when you are in 300 level. There were a lot of midwives in that area. The area was very densely populated. So one of the fastest moving medications were misoprostol, of course, in that particular area. But then you look at several studies talking about using substandard misoprostol, using quality misoprostol, and how it should be used, when it should be used. And you tell those people, oh, this brand you are buying is generic. I don't trust the source. I don't trust the quality. I trust the quality of this. And they tell you, but I cannot afford it. But that's what Pharmacy Nana is talking to us about now. At Field we have managed getting. You don't need to have money. You just need to sign up on our platform and we'll get it across to you. Apart from community pharmacies, we have been working extensively with the government across Nigeria. And at this point, I would like to call on our government specialists. We are in Nigeria, we are in Kenya, we are in Rwanda, and we have also moved to Senegal. So I'm sure our colleague from Kenya is here. But before she comes on board, I would like to call upon our specialists here in Nigeria who have been working with the government. They've gotten the calibrated drapes into several states in Nigeria. And just tell us about their experience, how easy or how hard it has been, and what is happening there. Victor, can we hear from you, Victor?
Hi, good afternoon. Good afternoon, everybody.
We can hear you clearly, but we can't see you, but we can hear you.
Okay. So firstly, I want to say I resonate deeply with what Pam just explained about calibrated drapes and the request to interfacing with a lot of government facilities, communities has really been interesting in the past few months, especially concerning the commodities we are pushing into the market, the life-saving commodities. I've had experiences, for example, in Akwa Ibom State, in Calabar, of how it was through the aid of drapes, for example, that accurate measurement for blood loss was used to save certain patients at a point. So when we had trainings with the matrons, had trainings with the gynae specialists and some pharmacies, the feedback we usually get is, where has this been all this while? Where has this been? If we had this, we would not have recorded so and so loss. If we had this, we would not have recorded so and so loss. And aside from saving lives also, it also brings a source of excellent practice to how they attend to patients these days. Because for example, I had a feedback from Akwa Ibom, University of Uyo Teaching Hospital, of how since they started using calibrated drape, their wards and their labor rooms are no longer messy. Blood, for example, because we're using sponge method. Now it's easier for them. And I don't know, Yewande, if you remember the training we also had with the Safe Motherhood team and Uyo Eli. Yes, I'm going to share my contact. If you remember the training we had with the Safe Motherhood team, how excited they were about calibrated drapes coming into the state. So it's a beautiful introduction we are doing. I was in Delta last week, and I remember the first time I spoke of this facility concerning calibrated drapes. The gynae doctor wanted it, but the procurement person was like, would they buy? Is it really important? And I was like, 1,000. I called the price and I was like, that's barely the price for a recharge card these days. Would you want to put recharge card over the life of a mother? Because yes, she's bringing life into this world, but should we end her life also? And she was like, okay, we'll just give it a try with few pieces. I think they got 50. From getting that 50 some months ago, my phone has not rested because they are seeing the usefulness, not just life change, practice is improving. So yes, it's beautiful. It's beautiful what we are doing at Field, getting it to inner communities, getting it to already established teaching hospitals. It's a beautiful work we're doing. Thank you, Randy.
Thank you so much, Victor. How many states have you, for you now, how many states are you working with now?
I'm currently working in the South. That includes those states, Delta, Bayelsa, Port Harcourt, Akwa Ibom, and Calabar. That's 6 states.
Thank you so much. So if anybody is listening to us, please, Victor is the man to reach out to. You can reach out to either the WIFPSA or Field, and we'll give you the contact if you want these medications. Is Tobel on the call with us?
Yes, I am here one day.
Yes. Definitely like to talk with you today, and let us, what has your experience been? Where are the states that you have been able to get these molecules in, and what more would you want the government to do, or anybody listening to this webinar here or after, to do, this information? Thank you.
All right. Good afternoon, everyone on the call. So I will start with an experience. I'll start with 2 experiences. The first was one in Niger State, Mina. We were at a workshop. That was sometime in May. And one of the facilitators was the emotive consultant for the states. So he stated while training the healthcare practitioners on how to use the commodities. Please confirm you can hear me.
Yes,
All
we
right.
can hear you very well.
Thank you. So while training them, he gave them a statistic of having been on the emotive training, that the rate of women dying due to postpartum hemorrhage has dropped from 34% to 7%. Why? Because they now use the calibrated drape. He's speaking as the head of gynae department and also the chief medical director of the institution. This is from Niger State. I'll take you to another experience in Pangshin local government of Plateau State. I covered in North Central, where I walked into a hospital and the woman was, she had to deliver at home, I think for economic reasons. And she bled out for about 4 to 5 days. Later, the husband had the sense in him to take her to a proper hospital, the general hospital in Pangshin. Interestingly, the 4 people that attended to her were the people that we trained on the use of this MSC in each commodity. So when I asked them the feedback, they said I had to transfuse 5 pints of blood to save this woman. Now, I want to join these 2 experiences together. From the look of it, there are those doing their best and there are those that are not even aware of what's happening. A month ago, someone called me on a Saturday like this and asked if I could supply 2,500 units of calibrated drips. I was like, wow. I didn't know where he was calling me from. So I told him, let's meet on Monday. So when we went on Monday, the conversation was about upfront payment and all. And guess what? He paid even before they saw the items. So the question lies here that there's a lot of conversation, a lot is going on behind the scene. But I think some people still need to do more where it comes to informing people these things are available and where they are available. What I'm trying to say in a nutshell is there's a lot we're doing in the trainings, in the sales, in the advocacy. But I think there's still a knowledge gap where those that are trained have not come to appreciate what this is all about. And those that even have the commodities do not really appreciate the affordability that we're offering to the market. So I'm hoping that maybe from this call, we both know that we not just sell, we do the advocacy, we do also do the training. But for the statistic, I think there's a document that says, I think it's 10% of women that put to bed die due to postpartum. 8,047 die out of every 100,000 women that are delivering. So if a place like a general hospital in Niger State is telling you they dropped deaths from 34% to 7%, it shows that a lot has been happening and a lot could still happen. Thank you.
Thank you so much today. I mean, 34% to 7%. That is remarkable and should be noised abroad. That is families that have been saved. I mean, we had a webinar where we were talking to a particular doctor. It's on our YouTube channel. And she lost her mom. And she was saying that she has not recovered from it. apart from the economic burden that this stopgap, these preventable deaths are placing on the community, the loss of a mother in a home cannot be quantified, or even throughout the lifespan of the children in that family. I'll move quickly now to supply chain. In this aspect, I'll be calling on Shion. There's a lot of economic burden that this plays on our society, either in Nigeria, either in Ghana, West Africa, anywhere it is. Economic gap is great. Some people have tried to model what this economic impact has been. We'll be talking a bit on the study. But before we go into the study, I would like Shion to tell us about just a scenario where we want to follow a product like oxytocin. Oxytocin is like the most commonly used, right? Oxytocin is supposed, so we want to follow it from the manufacturer to a rural clinic, or let's say an underserved area. We want to follow it from there. Where do the delay or the gaps typically occur? Is it from the warehouse? Is it transportation? Is it something else entirely? And I know that you are not a pharmacist, but you are in the field, so you are an honorary pharmacist, right? When there is no oxytocin, or there is no light, there is no block, what else? Over to you.
Thank you, Wendy. So like a good example to use, like you said, is oxytocin. And just for a regular person like I am on the call that's not a pharmacist or doesn't have that medical background, oxytocin is a hormone that's produced by the body, and it's useful during labor to help with contraction of the uterus. And oxytocin itself as a drug is, as an injection, as a medication, is cold chain. So oxytocin is meant to be stored between 2 to 8 degrees Celsius. So it shouldn't go below 2 degrees Celsius and shouldn't go above 8 degrees Celsius. So here comes the story that Oyewande spoke about, freezing pure water nylons or pure water bags to be able to keep the oxytocin within that temperature window. So let's start the oxytocin journey from the manufacturer. If it's a local manufacturer, typically they have, cold chain facilities. They have cold rooms where they store the medication. And then if it's oxytocin that's imported, say the manufacturer is abroad, somewhere in India or wherever, there's also the part that has to do with shipping it down to Nigeria. When it comes to Nigeria, typical customs, clearing and all that takes time. And as we know, it's meant to maintain that temperature. It's meant to be in that temperature. So that gap is from the manufacturing side of things. For wholesalers that get oxytocin from the manufacturers, they have to have equipment to be able to store. And by storage, I mean even from the transportation. So it's leaving the distributor or the manufacturer's warehouse to the wholesaler's warehouse. It needs to be stored, using cold chain devices, either a cold truck, depending on the volume, either a cold truck or a cold box. Those equipments have to be readily available. When it's at the wholesaler's warehouse, it also has to be stored in a cold room, in a refrigerator to ensure that it's within the temperature. And you also have to have constant electricity or constant power. We know the situation of Nigeria and how that works. And then we come to the health facilities that go to these wholesalers to procure. So even the public health facilities, or the private ones, hospitals, pharmacies, patent medicine stores, whoever goes to the wholesaler to procure oxytocin, they also have to have facilities to store, right? And as the case may be, even the public health facilities, if you do a survey, I'm not sure how many percent would come up as having either refrigerators or just the facility to store oxytocin. So that in itself is a challenge because we've not gotten to that level in Nigeria where, you know, these things are readily available compared to, you know, other developed countries. So that's very important because if the temperature goes either below 2 degrees or above 8 degrees, it renders, you know, the products impotent and can't be administered anymore. So then the burden lies on the, you know, where patients are accessing care. So what do they do in this case? That's where heat-stable carbetocin comes in. So like the name implies, heat-stable carbetocin for like a layman like myself is like a synthetic form of oxytocin that does not need to be stored, you know, in cold temperature. So you can store it in as high as 30 degrees Celsius. You know, it can stay in room temperature. It doesn't require any special storage or distribution conditions. And, you know, that's another solution that, you know, probably a pharmacist on the call would throw more light on how it works. So it's basically the same thing. It's like the refined form of oxytocin that can withstand temperature, larger temperature windows. And then talking about, because I was still linking back to supply chain, talking about supply chain gaps. For instance, there have been situations where, you know, we are trying to ship products to other parts of the country, and for some reason the roads are blocked, you know, there's flood or there's an accident and the truck ends up spending 1-2, you know, days on the road. Looking at that in itself, it's a challenge because even if you store in a cold box or whatever, there's also limitations to that. So, you know, it has to do with, you know, proper planning from the supply chain side of things and just ensuring that the facilities and, you know, where we supply oxytocin to, they don't get stocked out, because if we get stocked out, they also get stocked out as well. So we have to, you know, plan properly, plan our routing, you know, most times have to air freight, you know, the oxytocin to ensure that we are supplying quality oxytocin to, you know, the end user, and also guaranteeing that, you know, at these facilities, you know, the oxytocin is also stored, you know, within this, you know, temperature windows. So yeah, so that's a journey of how oxytocin gets from the manufacturer to you, you know, the end user. That's the receiver of this medication. So yeah, you want it.
Thank you so much, our honorary pharmacist. Thank you. So we go ahead.
Yes, so to speak to, thank you, Sean. To speak to what Sean just stated, we're in a sector where sometimes people want to cut corners. I will just share my experience here with oxytocin. We're making a delivery to a federal institution. So normally we have fulfillment partners that will go with the items, but on this occasion, we didn't know if they had the cold chain facility in place. They told us they did. So I think I had to make the visits with them, with the delivery person. Oh, so when I got there, we didn't open our box. So like she stated, we put thermometers to track the temperature. It should be below 2 degrees Celsius. It shouldn't be above 8. So I'm getting to this certain DMA. They actually thought I just came to make the delivery, but I first had to get into the coaching room and look at the thermometer first to be sure it was within that temperature. And why do we have to do this? To be sure of the quality of what we're giving them, because there's the possibility where we won't give them quality items, but they don't store it properly. In an event where there are issues, it might come back on us. What am I saying with this is we do our due diligence, like Sean just stated, to make sure that you're getting the right medications and at the right temperature. This is for oxytocin. I'll still speak more to the HSC. Thank you. Just to add to what Sean said.
Thank you so much for shedding more light on that today. It seems that there are several gaps that we can identify, and I think you will agree with me when I said in the beginning that this is not just a medical crisis, it's a logistics and access crisis. And we can see that having someone like Sean on the team, people like Mary, the digitized supply chain that we have at field is aimed at combating this, to ensure that from the manufacturer down to that rural clinic or that community pharmacist like Pharmacist Nana. We are managing our eliminating all the gaps. This is something that we've been doing for over 10 years. And now we are doing it in maternal mortality to ensure that we have more mothers safe. I want to talk on, I want to go into the business side. I know we're already in the solution aspect, right? So I want to go into the solutions part, more now into the business part. For the business people that will be watching this after, and for those that are participating in this webinar. And I'll be calling on one nigger to discuss this. You know, we talked about the fact that, okay, Field has introduced the bundle, the postpartum hemorrhage bundle. And the bundle has been designed according to international, health bodies recommendation on this is what you need to prevent or manage postpartum hemorrhage when it is happening or before it is happening, or even after delivery, just as you heard her talk about the drapes. From a business perspective, you know, one of the things you'll be looking at is, okay, we have made it available in Nigeria. We have said that we'll deliver it to you for free. Delivery is free wherever you are in Nigeria, in Kenya, in Rwanda, in Senegal. We are going to deliver it to you. We are going to ensure that your delivery cost is free. Some people might be saying, okay, delivery cost is free. What about the product itself? Mrs. Nana has mentioned that we have a solution. Through ShelfLife, we have what we call managed credit. You don't need money up front. All the states that Toby and Victor are mentioning, they are not paying up front. There's a payment plan. The community pharmacies, there's a payment plan. The hospitals, private clinics, there's a payment plan. From a business perspective, one acre, can you break down what are the significances of the financial barriers in this situation of maternal mortality that we're talking about? In the situation of how mothers, how stock-up is killing mothers. How does the simple lack of ready cash, how can it lead to stock-up? How can it lead to the loss of the life of a mother, either in a community pharmacy, in a hospital, and marry it to what we are offering?
Okay, thank you so much for that question. I'd just like to say that simply when providers don't have cash on hand, they tend to delay purchasing medicine until a patient presents with an emergency. I've been in hospital sectors. I've also been in personal situations where I've witnessed this providers not having cash at hand to stock necessary medications for their patients, especially emergency cases. Now, but in the case of postpartum hemorrhage, that delay can actually cost a life. A stock-up now happens not because the medicine doesn't even exist in the country. I've listened to everything everyone has said now, and I can tell that these medicines are available. Stock-out doesn't happen because the medicines are not available, but it happens because it was never purchased and placed on the shelf in the first place. What I'm trying to say here is that the absence of ready cash today can actually, become the absence of medicine tomorrow. And in postpartum hemorrhage, and readiness is everything, you actually cannot afford to play catch up with readiness around anything concerning postpartum hemorrhage. And that's why we cannot afford to treat this as an ordinary supply issue. I'm glad that we have these solutions available. And we all, at this point, I'm sure that people who have even joined this webinar, who are not your team members, would have understood that it is an emergency situation that has to be dealt with as such. It doesn't give notice. It doesn't actually wait for budgets or procurement cycles. What this means is that solutions must be put in place before the bleeding starts. Looking at from the financial aspect of it, what are some of the models or financial options that could be available to mitigate these challenges? Like you rightly mentioned, you said you have managed credits or even vendor financing, where from my understanding about this aspects or this opportunity or this model, it's a model that can give maybe facilities, government facilities or pharmacies, whether community pharmacies or hospital pharmacies, access to medicines on credits and pay later. It's been done. I've seen it being done across the pharmaceutical industries and their relationship with these facilities. And then after they can, after they would have provided care, some in the rural areas, some in the urban areas. Somebody mentioned something about the rural areas not having, enough medicines to support the women who will be needing it in the case of emergencies. So if we have this managed credits or even what is called vendor financing available, which I'm sure your company has, it will go a long way to see how we can save lives and ensure that the women are not dying as a result of stockouts, which invariably leads to maternal mortality in this case. Another model that can also be looked at is a revolving fund for health commodities. There's something called seed fund, which is usually set up for essential medicines. So what facilities do is that they draw from it to stock supplies, essential supplies that they'll be needing in situations like emergencies. And at the end of the day, they do some form of repayment plans, with the companies or the pharmaceutical companies that are supplying these essential supplies. Another model that could also be looked at will be the pooled procurement models. Instead of buying, I've experienced this during my time actively working in the pharmaceutical company industry. Instead of buying as individual accounts, you can have like 2-3 accounts coming together to pool their funds together to form a model that is called the pooled procurement model, to ensure that they get enough medicines, essential medicines for their patients. That is in the case where there is lack of cash. And in order to mitigate maternal mortality or any other cause of death, they come together to pool their cash to ensure that they have essential medicines available for their patients. So basically, I think that's how we have spoken about how it can directly lead to stockouts. Stockout can directly cause loss of lives, and then how we can mitigate to this loss of life to ensure that the patients are attended to as the case may be, that the medicines are provided to these patients, as at when needed. Using all these models that I've rightly pointed out, one of which I have heard about during this meeting, you've mentioned that you do manage credits or vendor financing. Other models that I've mentioned as well can also be put in place to ensure that we do not go ahead to keep losing our mothers or have an increased maternal mortality. Thank you very much, Yewande.
Thank you so much, Waneka. That was so well put. Jennifer, please, I would like to get your input on this.
Okay, thank you so much, Yewande. I was also trying to say that talking about the managed credits solutions from supply chain, from field, I want to take it back to what I've, some of the issues that we've seen working in the field. Why we are talking about it, we are talking about this from a practical point of view. That these hospitals, they need this medication, but because of, like Waneka rightly mentioned, the funds are not there. They tend to pick on what they buy. And then you can now imagine when a mother needs this particular solution, just like you mentioned, and it's not available to save the life. Now, before we even start going into the managed credit model that you guys mentioned, can someone from field actually mention how much is this calibrated drip? Because we've been talking about it and we've been talking about credit, and someone hearing it would even think that maybe it's very expensive. That's why there's a managed credit model around it. Can someone actually mention to the audience how much is this calibrated drip? How much is this bundle that we've been talking about, that we've seen in practical sense, that have saved life? I heard someone mention, I think I can remember the person that mentioned about it from the key account point of view, how maternal mortality has been reduced from 34% to 7%. That's a huge, that's a huge number, and we can imagine what that would do if we are replicating that in different government hospitals. So how much is this bundle? And how much are we even talking about, first of all? And then the managed credit model from field, how this is helping every other person to make sure that they stock this intervention, or they have this intervention as at when needed. Please, can we know how much this bundle is? Let's even know how expensive it is before we talk about the managed credit model.
Yes. So thank you, Jenny. So I will answer the managed credit model. I will show it, but I want to talk extensively about the costs. Because our own price, the price in the market for the other molecules, and you'll be shocked to see how it affects our accessibility. So be over to you.
All right, thank you, Andy. Thank you, Jennifer. So for the calibrated drip, it goes for 1,500.
Just 1,500.
So when I gave you the statistic of reducing PPH mortality due to PPH from 34 to 7%, so this is how it happened. They included one pack of calibrated drip in every delivery pack for the women. What this means is that as a woman is put into bed, you make sure they use the calibrated drip in addition to other uterotonics. So that's how they achieve that percentage. The calibrated drip goes for 1,500. Thank you.
Okay, thank you so much. You can imagine just 1,500. 1,500 is something someone can use to buy. 1,500 to save a life of a patient. I think we should look into this and even see how stakeholders who are in this call, how we can support this model, how we can support this push, how we can support this, because 1,500 to save a life of a mother is not a lot.
The cost of credit.
It's not a lot. 1,500 is something you can even spend in a city, maybe buying snack or buying, pastries or, whatever. 1,500 is low. That's why I wanted them to talk about the price, because when we are hearing the managed credit model, we could be thinking that maybe it's so expensive. That is why the managed credit model is there. No, we are looking at it vis-a-vis what are available, other options available in the market. And we're seeing that this doesn't cost a lot. It's something most people can afford. And then to also make it better, to ensure that we have improved access, the ShelfLife team has also gone the extra length to include the managed credit model, understanding how our healthcare system works. So I think it's something that they need to be applauded about, and I think it's something everyone on this call needs to push. We need to keep pushing about it. We need to talk about it. We need to introduce our community pharmacist friends. We need to introduce the doctor friends. We need to introduce the hospitals. We need to even make policies around it if we are in government, to ensure that this awareness is there, and to also ensure that the facilities that need them actually get them. Because one, is not expensive. Secondly, there's an alternative for people that cannot afford to purchase as at when they need it. So I think this is actually going to save life, and I think this is actually going to reduce the gap that we've been talking about right from the onset of this webinar. So thank you so much, and that will be it from my end to add to what Monica just said.
Thank you so much, Jennifer, for saying that.